Perfect. Okay, good morning. Welcome to Manchester. Welcome to this beautiful venue here in Manchester, and we've brought lovely weather as well. Hopefully you'll have an opportunity to have a little stroll at some stage around the gallery downstairs. My name's Bill Newman. I'm here as the lead of the Network of Excellence for Pharmacogenomics and Medicines Optimisation. You may know that we've had a few of these network meetings already, starting in Liverpool about a year and a half ago. And what we wanted to do today was a little bit different. So there's going to be less feedback on what the actual network has been doing, but looking at some of the other opportunities, some of the other things that are happening across this exciting pharmacogenomics space, and some of the other programs that are potentially thinking about pharmacogenetics as part of their work. And so the field will be a little bit different today with a number of talks this morning with a panel discussion. But then this afternoon, we've got a set piece program, which is being led by Munir and his team around their program for the CERSI around regulation within pharmacogenomics, which should be great. You've seen there's a couple of housekeeping things that I just wanted to flag. There's already been an alarm today, so there's not going to be another alarm. If you've got mobile phones, please just put them on silent. If you need to take a call or whatever, just wander out. If you want to ask a question at some stage, there'll be some microphones around. There are a number of people around and about. If you've got any questions, any logistical things that you want to know about. So Barbara, who I want to say thank you to, is at the back, who's done a fantastic job in organising the whole event. But there are a number of other people from Manchester near the back and around. So Stuart, if you want to put your hands up, there's Chris, Chandra, Stuart, Anthony, who are at the back and can answer any questions. One of the things also I just want to say is that we hope over the next few weeks to be putting together an application for further funding for the Network of Excellence. We've already had some conversations with some of you in the room. We're happy to hear people's thoughts around what they think might be useful. Maybe some of the things you hear today might inform some of your thinking. That application process is going to be really quick. We would really like to know what people are thinking to inform that. We can't make any promises around what funding will be available. We don't know what funding will be available in truth. There's a program that we're planned to start in April next year for 2 years. But of course, we need to see from the genomics unit, NHS England, which things they want to prioritise and which programmes of work they're interested in. But if you've got questions around the Network of Excellence and you want a bit of a conversation around that, then John's here at the front, who works very closely with me on it. Chandra's at the back, who's pulling together all the paperwork, and I'm around as well. If you don't get a chance to speak to us today in person, it's not because we're trying to avoid you, it's because it's just a busy day and stuff. So do email us and we can set up a call or have a conversation with you. Okay. Last week, a number of us were at the ESPT in Rotterdam, which was lovely, but also it was a fantastic opportunity just to hear about what's happening in other places in Europe and to get a sense of, what we're doing in England, in the UK more broadly, but how that fits into a much broader picture of particularly implementation around pharmacogenomics and the opportunity to learn from different groups. And we'll be hearing from Sandosh and their programme in Scotland in a little bit. But without further ado, what I'd like to do is to invite our first speaker. So that's Rich Scott. Rich will be known to a number of you. He's the CEO at Genomics England. He's been in charge there for a couple of years now, but before that was the medical lead on a number of their projects, and they've got an exciting program that he's keen to share some of the thoughts about, and then to hear what you think about it as well. So, Rich, delighted to have you here in Manchester.
Thank you. Thank you so much. Let me just sure I'm advancing in the right way. So, as Bill said, I'm Rich. I'm the CEO of Genomics England. I'm a clinical geneticist by background. I am not an expert in pharmacogenomics, and nor are we at Genomics England, and that's why we're here to spend time with you today. And it will be a triple act. The other two parts of the triple act are currently just about to get in a cab at Piccadilly, and they will be WhatsApping me about exactly when they'll arrive. So I think they'll arrive just at the bit that they're going to take over, but you might get a tiny bit more of me than anticipated. So what I was going to do myself was start setting the scene about some work that we're exploring that will include and heavily focus on pharmacogenomics. We're right at the beginning of the design and engagement on this, and that's why we wanted to come to you today to tell you a bit about where we are in terms of the conception of this idea, but also we're going to have a chunk of Q&A towards the end. Bill's very kindly agreed to join us on stage, but actually the idea is for it to be a sort of a Q&A, very much including the audience. And I, Katie, and Katie Snape and Ellen Graham, who are the others from Genomics England who are here presenting, are going to be around all day. So we're also really keen to spend time talking to you and hearing from you about your reflections on what we've said. So probably all of you know a bit about us as Genomics England, but we are a government-owned company. So we're owned by the Department of Health and Social Care. And we've been around now for 12 years. And one of the things that we've had the last actually 5 years is this vision statement for us, which is a world where everyone benefits from genomic healthcare. What's really key, and it's, all of you will feel this in the audience, I'm sure, this is a team sport. It's about making that progress, enhancing the impact that genomics can have for health outcomes together, and different parts of the ecosystem, different organizations, different experts feed in different ways. One of the things that we've been doing over the last couple of years is casting forward the next 5 and 10 years to think about where we need to focus. And we're doing that, and I'll talk a bit more about that in the context of where we think, and we're really optimistic, we as a country can go as a whole. But always, obviously, within mind where we add value and also where we definitely don't. And again, back to that point, this is new territory for us, which is why we're here with you today and really keen to engage. Lots of you will know about our different elements of our work. So we started through the 100,000 Genomes project, delivering a research study about diagnostic use of whole genome sequencing. We've transitioned into supporting clinical care in the NHS in England. We have also continued to run research studies. So the Generation study is an example, newborn sequencing, they're screening, but still in a rare disease setting. And we also run now a research environment, so providing access to researchers to research consented data. And on the screen are sort of the 3 big areas where we have the most expertise as an organization. There are large white spaces around that in terms of where we don't. So just sort of worth saying where those are. So the largest number of people at Genomics England are people who develop, build and run digital systems, whether that's for the NHS or whether that's for our research environment or to support our research programs. And that's sort of important, a really key part of the core operations that we have. We really believe, and this plays out in a number of ways, that thinking about how you can run research and support research studies that result in change of healthcare practice is super hard. And that's why all of you, I'm sure, are here today, about making a change in healthcare. And so we spend a lot of time thinking about the sorts of programs that we can support and in some cases run to move the dial in terms of how genomics is used in healthcare, and how that evidence we can make sure it is actually acted on by policymakers rather than being terribly interesting and impressive on its own. A really key part of that for us is the breadth of the evidence that you need to generate to make the right decisions, and also to make sure that the design of future policy is in step with public opinion, matches expectations of different communities, and therefore for us, engagement, ethics and equity expertise within the organisation is a really key part, if you like, of that evidence generation piece. So if we've been doing that thinking the last few years, we've been doing it as part of sort of wider government thinking on future strategy. We feed into things like the 10-year health plan for the NHS, the life sciences sector plan, which came out earlier this year. And I've drawn out some of the elements that were mentioned in there related to Genomics England, or that we contribute to some degree towards. One of the headline statements in the 10-year plan about genomics is this level of ambition for how much impact there is the belief that genomics could have, and up to half of all healthcare encounters informed by genomics. And we'll come back to that. Thinking about the digital infrastructure that needs to support that, and we say an important role of us contributing to elements of that digital infrastructure. Focus there obviously on elements. There are many different components that need to work together. We're completing the generation study. We're going to and getting ready for that evidence to be looked at by policymakers to inform what the government's ambition is that might be adopted in the next 10 years, and supporting clinical trials, particularly in cancer, and supporting the growth of our genomic research library. In the middle, and this is the real reason to bring us here today, is the idea of what we're at the moment calling an adult population genomics program, with the aim of beginning to build evidence and digital infrastructure that could flesh out what the path towards that vision in 2035, where genomics is much more part of everyday healthcare. What are the gaps there that we can support filling in so that future policymakers can make those decisions, and that can come to be. So in the light of that, we've refreshed our organizational mission, which is sort of very much thinking about our role, providing evidence and digital systems, so that that vision that's set out in the 10-year plan could come to life. It's also about playing our contribution in making the UK a great place to be a genomics innovator, whatever your style of innovation, whether that's a new use in a certain clinical setting of existing tech, or if you're someone with a new sequencing technology, or an amazing AI algorithm, or one that you want to develop. So when thinking about what the gaps are in terms of the evidence, the things that we need to build out and consider, so we always like to sort of think backwards for where one might end up in terms of the uses of genomics. I'm not going to dwell on this slide for too long, but we spent a lot of time thinking about sort of the different settings. And actually, I think a real key point for us here is how different those settings are in multiple different ways, in which we see the potential, either because there's evidence here and now, or because there's important research questions to explore the potential for the use of genomics through the lifetime at different stages. We see, and when we read the NHS 10-year plan, we see that path with those different potential uses of genomics, and particularly the opportunity in pharmacogenomics in the adult setting to be a real trailblazer for the sorts of things that the 10-year plan talks a lot about, and you'll have heard it when the government released the 10-year health plan about those three shifts that they talk about, from hospital to community, from analog to digital, and from sickness to prevention. And as we look at that sort of future casting and think about what a path to that might be, we're excited. We think the UK is uniquely placed because of the expertise in this room, the expertise across industry, and some of the infrastructure and the long-term investment that government has shown it's committed to in genomics. But there's a lot to do to get there. This is not a given, and it's about thinking about what that path is. So one element of that is the thinking that we've put in and are just beginning and wanting to talk to you more about today about this adults program. One of the things you'll notice is we don't really like the name, the Adult Population Genomics Program. It's a Ron Seal name that we're going with for now. In time, we can come back to the best naming for it. We're just at the beginning of thinking about the shape and what our role and what this program should do, because there's lots of work in this space. This isn't the only thing that should go on, but we think it's going to be an important component. So this slide sort of summarizes where we are in terms of the bare bones of the program. It's a translational research initiative delivered by us in partnership with the NHS. I hope, with the Network of Excellence and others, with the aim of generating evidence and building digital infrastructure to support decisions by policymakers in the future on how preemptive, I think that word's key, and the biggest focus of us in this program overall, genomic testing is best adopted to improve health outcomes for the adult population. The aim of the program is also to support ongoing discovery research and work out how we can continue to learn through participants in the research study itself joining the National Genomic Research Library. And in the program, we'll talk a bit more about the timelines, but the government commitment is to this being a 150,000 participant research study. So hopefully that sets a bit of the scene. This is the bit where I become someone who's not Katie Snape, and they will walk in, and so I'm slightly imagining sort of Mrs. Robinson or some, maybe it was the end of Four Weddings and a Funeral. People rush in at the back of a room, slightly like this. So they will arrive shortly, and they are struggling in their cab, is the latest update. So I'll keep going. So I'm going to talk to you a little bit first about the sort of considerations, some of the background, and this is very much sort of motherhood and apple pie to lots of you in the audience, some of the elements or a lot of the elements of this, and then tell you a little bit about where we are in the early discovery phase, so that then we can go into the discussion, and we'd love your thoughts on any of the questions. So as I said a couple of times, this is really new. It's new territory for genomics at scale in sort of any health system to start thinking in this, be wholeheartedly preemptive in terms of genomics. It's definitely new territory for us at Genomics England. I think it's less new territory for some of you in the audience, but we're really cognizant of that, and that both thinks about who we need to partner with for the program, what expertise we need, but also how we design the program itself and the questions and the evidence that we need to develop. So this is thinking about offering genomic testing in a preemptive population-based context for those benefits. So offering that outside acute care, thinking about how that might imply how people might join the program, or in the future might say that they want genomic testing to be carried out on them to inform their healthcare. It may use non-NHS settings, which is a departure for us for almost any of our previous programs. Thinking about the return of findings in a pharmacogenomic setting, but also in a common disease setting. The scale, the number of findings is a different model from one that we've engaged with historically, which has always involved all results being seen by clinical scientists. So one really needs to think really carefully about how that model is navigated. And this is very much about embedding in routine care, where in rare disease and cancer, plenty of hurdles, but also plenty of experts who consider it part of their role to engage in this. This is not the model. And again, none of this is new to you, but it is something that, as we think about the program, is really important. As I said, we're really attracted and struck by the importance that pharmacogenomics could have. And we think, based on the work of you in this room and others, is the sort of the primary and most promising immediate use case for adult population-based preemptive genomics. We think that there are broader questions. We think that the future will also include better risk prediction at quite large scale for common disease risk, but we know that there are more gaps in the evidence on clinical utility there, and that's part of the role of this program. We'll explore some of that. But this is definitely the slide that any of you in this room would talk to better than me personally. But we're really thinking about the impact on both adverse reactions and on better tailoring of medication for efficacy. We're really cognizant of the importance of rare variation as well as common variation in pharmacogenomics. We're also really interested to understand, this is data from 100,000 genomes participants of different ancestries and the frequency of rare pharmacogenomic variants of various frequencies. We're really struck by our experience already.
Sorry, just struggling to look at the aircon, if that's okay.
Sure.
I'll put it on for you.
Good, thank you. Hopefully this is better. So this is actually a slide of allele frequencies for rare disease variant prioritization in the 100,000 genomes project participants, showing, I think this one advances, showing that for example, here in African ancestry populations, the much higher number of variants of potential clinical significance that are highlighted. Here's our full weddings and a funeral moment with the other team members joining. Come forward, Katie and Anna. So I'll introduce them as they come. So this is Katie Snape, who is our principal clinician on population health and is a clinical geneticist by background, with an interest, and lots of you in the audience might know her, in cancer genetics, and Ellen Graham, who is our service owner, so the director of this program. Many of you will know Ellen, who used to work in the genomics unit quite some years ago in NHS England, and has worked most recently before here with Amanda Pritchard, CEO of NHS England. So Katie, why don't I finish this slide? We let you can catch your breath. We'll work out quite when we transition. Again, I guess this slide really highlighting the importance of recognizing that there's a lot that we don't know in different populations, and that rare variation is really important to recognize, both for action today based on knowledge, but also that there'll be much more to learn. There are a good number of lessons here. One is thinking about the representativeness of the communities that we recruit to this research study, and a second is thinking about the right technologies for the study. And we are committed to this being a sequencing-based study, so that we can identify with confidence rarer variation and also learn about variations less well picked up. This is Katie's slide. So look, Bill's sorted over water, and I'm going to hand over.
Thank you. Thank you so much. Sorry for being late. Rich has, thank you, talked about the use of genomic sequencing for pharmacogenomic variants and why we think a sequencing approach is important. The other thing that we're going to be looking at with this is the genetic contribution to potentially common disease, and thinking about whether we can use information not only for pharmacogenomics, but also in potentially predictive and preventative healthcare. So that's where my background in cancer susceptibility and risk prediction comes in. And you probably know this already, but just to demonstrate that almost all common diseases are an interplay of genetic factors and environmental factors, or lifestyle, medical factors, plus a dose of chance in there as well. And for 5 individuals with the same condition, and I'll talk about breast cancer because that's what my background's in, you might have somebody that just develops it by chance, as a chance event due to aging or other factors in the cell. And equally, we may have individuals who have a small genetic component to that risk, but it's only a tiny small genetic component to that risk. And in order to go over the threshold of developing a health condition, they would have to have a number of other hormonal, lifestyle, chance factors occur to take them to that threshold. Equally, there will be other people that are dealt a larger number of smaller genomic variants that can add up together and then again interact with other environmental factors to take us over the threshold. And when we're talking about kind of polygenic components to risk, this is what we're really referring to, these small genetic factors that individually confer low risks, but can cumulatively add up to really increase the risk of a person developing a condition. And then we have our kind of traditional Mendelian single gene variants, which are of varying degrees. So we could have an intermediate risk variant, or we could have a high risk variant. So something like BRCA1, for example. And this is the same condition, but you can see that there are different genetic components. Some of them affect single genes, some of them are spread as polygenic risk factors. And so how might we be able to use our information about the genomic factors to put people into stratified screening, prevention or early detection programs? And I think what's really key here is that we know that the genetic risk is only a part of the puzzle. So if you only return the genetic risk, you have quite large sort of confidence intervals and large ranges of what the risk of developing that condition might be. So a better way to try and deliver this information would be in the context of an integrated risk model, where you can account for all of the factors that might add up to take a person over the threshold. And so those genetic risk factors we might be able to look at through gene panels or through sequencing. We might be able to call SNPs as polygenic risk scores, but we would also probably want to consider risk in the context of other modifiable risk factors. And we already do this in cancer genetics. For example, we use CanRisk, which is an integrated data tool, which can take hormonal, lifestyle, medical factors, breast density, as well as monogenic risk and polygenic risk, and use data models to give precision risk scores. And ideally, in a kind of perfect utopian state, this is the type of precision risk we would want to undertake in individuals to give them more accurate risk prediction. So in terms of what we're thinking about with respect to the study that we've been talking about, we're going to need to provide some measurable outcomes, and we want to have sequencing data that can give us information across both pharmacogenomics and prescribing, but also potentially in that preventative space for common disease as well. But there is a little bit of a tension between that, because if you're doing preemptive testing, then you are doing a test and you don't know if a person is then going to have an event which is going to then trigger a prescription. And so you need to target your age slightly higher in that setting to have enough events, because we know that there are more drug prescriptions as people age. But conversely, if you were going to do something really preventative, then obviously you'd want to intervene sooner with an evidence-based intervention. And so managing that kind of tension is going to be absolutely crucial to the study. And there's probably a sweet spot around the kind of 50 plus age where we might be able to intervene in preventative healthcare, but also have enough prescription events as well. So one of the reasons we want to think about a sequencing-based approach, Rich has demonstrated we need to pull out rare variants, we need to try and improve equity and diversity of our data sets, which are not well served by other large population data sets at the moment. We want to support generating evidence on the utility of genomic data across a variety of different use cases, from PGX, but also to common and complex diseases, particularly probably the high risk of cancer and cardiovascular disease in the first instance. And also to drive discovery and to drive scientific discovery through the National Genomic Research Library. So I'll now hand over to Ellen, who will tell you a little bit about the work that we have done so far on this programme.
Lovely to be here, and I'm really glad Katie went first so I could get my breath back. So I just wanted to tell you a little bit about what we've been doing on the study, and apologies because I didn't hear exactly what Rich said. I'm hoping I'm not going to repeat anything, but the person I used to work with, Amanda, used to say to me, the best thing you can do when you're talking to people is just say the same thing over and over again, because then people will pick it up. So I'll take that mantra. So I just wanted to tell you a bit about some of the work we've been doing. We've only been working on this for a couple of months, but we're calling this phase our pre-discovery work. But essentially what we've been trying to do is gather the lessons from the other studies that have taken place. So talking to colleagues who worked on the setup of the Generation study, as well as the 100,000 Genomes project, and others from the NHS who have been involved in setting those studies up. We've started to hold some stakeholder interviews with people. I see some faces here in the room who've already engaged with us, and we've got more to do to hear about what's happened so far, what's working well, what things we need to think about, what some of the barriers and challenges might be. And we've started to do some user research. So we've done a little bit of rapid user research on the current pathways and how they work, particularly around the NHS health checks and how prescriptions are issued. But there's a lot more work to do in that space. Then we also commissioned a literature review from Father Health, and Father went and looked at all the existing evidence for us about the public and healthcare professionals' views, as well as about population level genomics. And it's been really helpful to pull together for us what is already known and also where the gaps are. So some of the gaps that have been identified, I guess none of this will be particularly new to any of you here, but that there are some gaps in the literature around health professionals' views from non-genetic backgrounds. So I'm sure you all know that from your day-to-day practice. That there's more work to do to engage underserved communities, particularly the existing literature focuses mainly on healthy, white and university-educated populations. So we've got more work to do there. There hasn't been a huge amount of research about the longitudinal value of genomic information. So a lot of the studies have thought about the genomic testing as a single point intervention rather than the lifetime value of the genome or using genomic information at multiple times. Basically, a lot of the research has looked at what people think about engaging with genomics rather than how effective those engagement strategies have been. So we want to think about how effective we can be at engaging with different populations and what that looks like and how effective those strategies could be. And some of the research hasn't necessarily looked at what people's views are about the service design that they're engaging with. It's thought more about their attitudes maybe towards health outcomes or risk rather than what the service design looks like. So to fill some of these gaps, we have commissioned a engagement strategy. So we're working with Hopkins Van Mill, Rand Europe, the Social Agency, People Street and the LEAP. And over the next few months, they will be taking forward lots of engagement, both with the public, with healthcare professionals and with specific communities. So they are going to be reporting, I think it's next summer, and they're going to be looking at people's perspectives on genomic findings, particularly pharmacogenomics, but also common disease risk, like Katie was just talking about. We're going to explore what people want to know, what information they want to know, who they want to receive it from, and why they want to receive it, what are their motivations. And we're going to also be exploring people's views on the use of their genomic data over their lifetime. So we are taking forward these three different elements through three different ways. So we'll be doing some surveys with healthcare professionals, as well as some detailed workshops. We'll be holding some place-based community engagement over a number of months with specific communities in the country. And then we'll be holding some public deliberatives early next year. So we'll use some of the insights from the different elements and bring them together. Yeah, so we started the healthcare professional engagement, so you might have already received one of our surveys, and if not, I'm sure we could share it with this network today, and it'd be great if you could fill it in and share it with your colleagues, because we're really keen to get as many views as possible. And so our broad timelines for the study is that we We'll continue to do our discovery work. So between now and the end of the next financial year, we've got a lot of engagement to do. We've got to write our business case to go into DHSC and Treasury to secure the money that was announced. And we need to work through the specific details of how the study is going to work. So we need to write our research protocol submission so that we can actually take forward the study. We need to work out exactly what the study is going to focus on, which cohorts, how we're going to implement the study, and check all of that work. So a lot of work was done on the newborn study to work out the testing methodology and whether we could actually get the results returned and the pathways work. So we've got a lot of work to do over the next 18 months. And we'll be looking to start the recruitment in 2027. And we will probably start in a small number of places and look to scale beyond. And overall, we're looking to sequence 150,000 participants. Rich, are you going to finish or do you want me to? So just to finish up, I think I would have come together perfectly with what Rich said this morning, but essentially we are trying to use the study in order to make that vision come true that Rich set out earlier. So this is about rolling out genomics so that everyone can benefit. Thank you.
Thank you. So, as I said, the aim was to leave a good chunk, which I think we've got just over 20 minutes for some discussion with the three of us. And then Bill has very kindly agreed to join us on stage. What we're keen to do is hear from you about your reflections on what we've said, questions that you might have about it. But also, we put these 4 questions up, non-exhaustive, but more like starters for 10 in terms of some of the areas for exploration we would love to explore, reflect on, get your views. And now, in terms of housekeeping, I think we'll have 1 or 2 microphones up here, and then if people, as you think through your questions, can put your hands up, then wait for someone to come with the microphone so that everyone can hear. So why don't we share this? Sit for a row. We can immediately start thinking about some of these 4 questions, but keen on both questions and answers to those questions. You might have a much strong views or responses to everything that we've talked about today. I wonder, yeah.
From the good one, are you thinking of doing work with young mothers? This is a group that I think is more represented there's a focus on diabetes, cancer, dementia, but I think young mothers is a group that we really focus on. There's a big deficiency in maternity care, in maternal health.
That's not an area that we've gone deeper, but it's a good one to look into, and part of a lot of this phase, the discovery phase, is working out where the different opportunities are. In our general view of this program is to sort of think about what the big set of questions are, recognise that any one program can only identify and tackle a certain number, and work out what that sweet spot is. So that's one of the things that would be great to.
Yeah, I was just going to add that it's very nice work in Australia, particularly in other parts of the world, recently thinking about carrier testing in the context of reproductive risk. And that may be something that also needs to be considered as one of the elements. Not to say all of these things I think should be done, but I think all of them need to be considered, because that's, I think, what is most important about these coming months. That hearing from people about what it is that is sensible, what we need to consider, what can be incorporated into the study, which is not for everything, but we want to prioritise the things like this those needing those opportunities. That's really cool. There's a question, oh, there's that there. There's many others.
Do you also think to do this person application and how we can test for 3.5 years with
So, yes, so can I just try to get it perfectly? Quite you.
I think it's about looking at those strong actions and looking variants.
I guess in general, we would aim is thinking about how creative using genomics, including in pharmacogenomics testing, can help outcome benefits. So we're really interested. We also recognise that thinking about how the program is run might favour certain types of benefits in about a subscription in primary necessity. That might favour points of benefits in certain settings. I don't know if I was.
Yeah, I think basically this really prove the concept a lot of really drilling down to define these spaces. And also what we can measure and metrics so that we can map those spaces that are evidence in the potential benefit program. And definitely those directions and those.
Thanks, so the biggest problem facing the healthcare is the growing health. 95 at the moment above 65, which is kind of running for, and a lot of them, at least 8% of the movement of patients without that on pharmaceutical medicines, and many people are 15 medicines and so on. And many people have shown within ourselves that the risk of stroke reactions, etc., related to that is huge. 15% of people with that. Two hospitals have stroke reactions. So what I'm clear about is whether you're focusing on incidence prescribing or prevalent prescribing of those. Clearly, in the hair trial, we were able to show incident prescribing could be improved by use of pharmacogenomics and then just transformation of methods. And much more problematic is the prevalent polypharmacy. People in care homes in hospital right now are on 15 drugs, etc. And those would be prevalent polypharmacy and what effect pharmacogenomics might have there. There's another trying to understand this, some incident or prevalence.
At the moment, that's one of the bits that we really want to explore, and that's realistically we need to decide what we're favouring most. I guess, and very much one of the reasons we're coming today and need to engage much more deeply on the philosophy is thinking about the more basic knowledge. Which is part of what we need to engage with there's not change it's going to be substantial. So I think we would love to think about benefits in both, but also realistically probably in the next 9 months so we need to really English part primary. So any questions from Bill?
And I was going to say that all our capabilities and what really is our classes is already really what's the ancient programs and things reliably and when learning as this program support, but also making sure that we're aligning what else to do. And so I think it's incredibly important we know that our sort of learning into this space as well. So that part of this supplement making sure we're relying and have feeding into this.
Do your figure show that in the elderly with less potential prevention? And That's true to some extent, but actually there is still information in the very relatively well.
Absolutely, and that is really more thinking about some risk relation to cardiovascular risk relation.
I think the all work and most work in this space is starting to address some of these challenges, but some of that work has been less mature compared to instant diagnosis, describing and comparing. I think one of the challenges and opportunities for this program is to ensure that if new evidence emerges through the course of the study is able to adapt to that and use the information that those extra benefits can accrue over time, then they might not be immediately possible right from the start of the study. That has to be taken into consideration and scientists talk about flexibility as such. But there needs to be very clear messaging about that. I think Jess, question, and there are quite a few questions around, so that's great. If I did it, you might be seeing the place. Yes.
My question would be, it's very hard to know as well in my own impressions, but the reason why pathogens are having an impact on health outcomes is only when you try new changes. And we're talking about people with the articles with producing non-NHS. So if you think about the purpose, the minute, the day, we see really high levels of the recommendations. And that's, of course, what we hope will then lead to the improved output. So I just wondering what your thinking is around ensuring that high will take the recommendations, because if we don't find taking prescribing changes, then there might see the benefits. Just how we propose to do that, and not potentially prescribers who are asked to test.
I think that's really, really important. So we think it's going to be quite a lot, and we've still got lots of things to do about protecting pathways. And one of the things that I was really excited about in the Genomics program was thinking about, if we're going to roll this program out, how do we do it in best? And actually looked at the way the NHS, given the huge amounts of misuse we've got, and the fact that it's potentially could be a burden into the system. So we're thinking about how to really potentially preemptively outside the NHS, but usually in the NHS. So we haven't decided any of this how it works, but there are elements of thinking about. I'm talking to probably in the progress today here about the excellent opportunities in primary care is really, really important. So we're going to have to work out what we're trying to look at and what aspects we are either choosing to explore in a different way, or we're doing something else. Keep all the options on the table. But that's what we're talking about when we're saying combination of thinking about perhaps really communities in different ways, so we can get up to forums, so we can improve people in different ways. So they're really able to do that.
I was thinking as well that the engagement to why all the need to ask questions like this, what makes you more likely to engage with information? And we expect it to be, is that deeply project compared to this result? You know, and probably, you know, the interesting parts of people who might have already times go to have needs to have their edges, they can't obviously very comfortable if the patient, but some information is possible to even write information. But they have difficulty with using what they have this information, for example. So I think that you need to ask people that, and then it's something really mindful of the fact of the effect of the engagement and should use the name.
There and there and there. We do that. And I was probably on that, about doing the trying genomic assessment case, and it's quite a strong recommendation to not be maybe or using the genomic assessment piece and balance the operations within the time results back. And I do want to be able to maybe the surgeon initially release this for
progress and actions also to involve this. Really, actually, it's not one that helps me. That's just one thing you really need to think about. Actually, having a session like this, thinking about all the different touch points that work in, might work, for reasons like that, and actually this is sort of creating a lot of this. I think that's a great one. That's something I'm really useful.
We should have this people listening. We have some rather piece of practice in digital infrastructure prescribing. There's an opportunity that happens to these optimization areas that all the guys learning schools. I suppose the devastating and very difficult birth challenge that they allow students to witness and many to experience. I want to consider a bridge there really between the loss of the work of applied to the initiatives. It is beautifully created rather than lucky rather than the genetic positions and staying on top. So maybe we could talk about the digital infrastructure part to that, but also the very initiatives with the teams who are going to need to probably transition that from some needs to neighbourhood projects. So there was the LA project, each of the teams are coming up with it. Either this is a project is right, or it underpins some of the principles of projects that are being set up. So when speaking to build in real practice, looking at your timelines that are one that we will probably want.
Thank you. Building on that, actually, from this question, just right here in person. Thank you.
Thank you. Great presentation. Actually, it's about the state of the using management and constant. Just on making two of the concerns that just suggests that mentioned in the part. Just on that, do you think it would be including challenges with document implementation as part of that research to help with the team going forward? What would that look like?
Sorry, actually, so I think one of the reasons for the reason about the development, obviously, vaccination is important, but also understanding how to implement the NHS and how to roll out what works and wouldn't it's actually really integrated. So exploring these elements I think is really key to this study. And that's why when we go about how to what you can focus on, and also thinking about how we're going to which bits of the country, how we're applying the different places and the different things. So I think the implementation side is as important because we need to do the perfect study and the intended time how much of what the NHS overall be able to implement this and hopefully something but I think we've got a role and responsibility to take both elements and that's why I think it's been really exciting.
And then we understand from the reasons of what's listed in this thing. Is that in touch things like using the elements part of that? Should have asked the data to make with where it was happening. There's a time when you can see that we've caused part of it. So that's something that's really hard to that's all to use to part of this approach and all that on time.
Maybe generally work in this area where you don't think about the Newman program where the one in one is really about tools are today that give you trust and get to the right level of implementation or essentially the returning stuff which people returning and receiving confident to act on. And that means that we're using today the very best of today implementing to build on about the ability to continue to invest and learn. That's a really key part of it. Part of the consent approach we generally take, and then specifically to program is to joining the national research library. There's also the potential for research parallel on the side to demonstrate and but you to link test it out and what's not side. So that would be a really key part of it.
One last one. And where the industry is involvement in talking on the last software actually using to test that and developed and methods to office tests.
Trying to mention yes, one of the pieces that we have was early discoveries during the first part of next year, many of the our research submissions, so it's thinking around the markets in the industry, we absolutely part alongside many in public sector settings in Israel as well. And so again, mirroring what we've done historically, we see history as having really well multiple data, whether it's our delivery providers and the various bits of technology, whether that's through some of the digital tooling. Also, the industry really pushing through the discovery bits, and we have an existing framework for that. So again, that's what we have people that visually face particular areas of interest, but that's important and something which will take more shape over the next 9 or so months in terms of how it's going.
Thank you. Chris, then please one at the back as well, so we can do this.
So for example, you're turning science, Genomics, Genomics chair. So I know lots of projects in Genomics research, and participants have actually created running recruited. So do you have a mechanism for retrospective farming and Genomics, actually etc. Taking the ideas that you're achieving program and participants that will be into research.
So yes, one of the elements of the bar chain consent to national research language, anyone joining to this program sign up to is something to collect health data. Do you get signed to data, not good for assessing Pharmacogenomics outcomes? That's going to be really a key part of the design of the program and working out who else we need to work with to make sure that data that is available various necessary to create tools for that.
Question back, and that's the last question, and we'll need to round up this section.
Thanks. There was a talk about prevention, and I guess what we should do really getting back on the important because it really engages to screening prevention. There's a risk you're driving in a field population that have no disease and maybe to prevention, and you are missing the opportunity for the population who are suffering basically I'm not sure what the life expectancy, I'm not sure what the future will be like. So whatever it's to be really key to adding the broad business.
It's something that's firstly, we definitely need to engage in that, how we are engaging communities and our focus capacities that is presented also says that as it's engaging we actually have an organization yesterday, public health consultant what do you do now? How many people do in those space? I think that's the life. We should be feeling is it population that we need population. And what I think the other thing I say has something worse in the past as well. I'm really conscious of over-diagnosis, over-investigations, and increases the burden into NHS pathways. So I'd like to absolutely sure is that we consider some pathways in this space, diversity, see the analyze the possible impacts of clinical impacts, and then we can see what the interventions are, and particularly if you nutrition without you can ascertain people to populations that have the risks and benefits of the interventions that are providing benefits. And so again, we should really be thinking about generating evidence in this different context, which is really
Thank you so much for giving us some time and for your questions. We're here all day, and so we're looking forward to more conversations during the day about any us to talk about it. And last, thank you for more asks to come from us, because we're really looking forward to
Thank you very much. That's been and I'm sure we'll be able to get the survey out when we do the follow-up so that everyone's had a chance to look at that. Thank you so much for that overview. So now we're going to move north of the border. It's my absolute pleasure to invite Professor Sandosh Padmanabhan, who's going to talk a little bit about the work that they've been doing developing the Scottish Pharmacogenomics programme, and I'm sure we've got plenty to learn from yourself. I'm going to give you this microphone because I think that's better. Thank you, Sandosh.
Thank you. So I'd like to thank the organizers for inviting me to speak about what we are doing in Scotland. As you know from the last talk, that implementing genomics is complicated. And I'm going to give you some insights into our experience in implementing or in trying to work out what to do with pharmacogenetics. So this is the Phoenix trial. I'll just give you a summary of what the Phoenix trial is, and then I'll go back and work our thinking and our logic and our ideas into why this is the approach that we are taking. So this is a randomized controlled trial in acute care setting. So we're looking at patients in the hospital, the Queen Elizabeth University Hospital in Glasgow. And the aim is to evaluate the clinical utility, feasibility, implementation feasibility, and health economics of pharmacogenomics in secondary care settings. I mentioned we initially focused on the Queen Elizabeth University Hospital, but we are now opening other sites. Unfortunately, it's taken a long time to get the trial going. And so we have a very short window, about 18 months to complete the trial. We started on April 9th, and we have to end. We have hard stop on September 30th because of funding. Our aim is to recruit between 2,000 to 4,000 patients, or randomize 2,000 to 4,000 patients in 18 months. As of the 9th of November, we have randomized 800 odd patients. We are using the Agena Veridose platform. We are going to change from Veridose 1 to Veridose 2 on the 25th of November. We have our decision support from MyDNA, who are a company based in Australia. And our endpoint is to look at incidence of ADRs and treatment failure within 3 months of randomization. So that's the overview of our randomized controlled trial. The big question is, why do an RCT in pharmacogenomics? We know that there's a lot of evidence about pharmacogenomics. We know that it's a lot of black box labels. There are labels about pharmacogenomic variants in drug formularies. But despite all the evidence, pharmacogenomics has not been implemented at scale anywhere. And the question is, do we just go ahead and do implementation, or do we still try and generate evidence? So there's been, it's a mixed story. When we look at implementing genomics or even pharmacogenomics from using non-randomized controlled trial evidence, there's a lot of examples of successes. And on the pharmacogenomics side, you have DPYD and mtRNR. And then more recently, we've heard about CYP2C19 and stroke. The problem is that if you look at DPYD and mtRNR, these are very clear high stakes pharmacogenomic variants. They each solve a single problem. The benefits and harm are obvious, and the volume of testing is predictable. Similarly, there is a safety mandate, a very high safety mandate. So that meant there would be swift national blanket mandate. The problem with CYP2C19 and ischemic stroke, here we are coming to a probabilistic model. So CYP2C19 and for stroke is an effectiveness question. The outcomes are probabilistic. And you can understand when you look at the NICE guidance, it's not a blanket mandate. It had a lot of caveats. And that brings us to a comparison of clinical genetics. If you look at monogenic conditions, high penetrance variants, that's an easy case to implement or make a case for adoption. But when we come to multifactorial conditions and drug response and most of drug adverse events are multifactorial. In a sense, if you look at most of the studies, it's a normal distribution. You don't have a binary distribution like you have with mtRNR and ototoxicity. Again, it's the same story between monogenic conditions and genome-wide association studies. Converting genome-wide association studies, despite the hundreds of thousands of variants discovered associated with conditions, it's been a big problem trying to convert that into clinical applications. So that's a background about implementing the sort of high value genomic applications. Then we come to observational studies. When you go straight to implementation study, we are talking observational studies. And observational studies may not be appropriate to go into first. We need to first generate the evidence and I'll explain that. There are lots of biases when we do studies. And the only way you can get compelling evidence is to have a comparator group, a matched comparator group. With pharmacogenomics, it's a lot of outcome heterogeneity. We've heard from the previous discussions, so lots of polypharmacy, drug interactions. Your liver function, your kidney function can affect how you respond to the drug. There's phenoconversion. Equity effects. Without randomized or matched comparison groups, it can go either way. And finally, when you talk about commissioning, people require robust counterfactuals. So we need system level evidence, and system level evidence means it is difficult to get those, but we need comparison groups. And this is the crux of the problem. Pharmacogenomics is one signal amongst many for drug response and drug toxicity in many cases. The NHS requires different levels of evidence for them to be convinced about where to allocate their resources. And again, as I mentioned, for commissioning, they require different metrics. And clinicians in current clinical practice, we don't do that well, but we already juggle drug interactions, polypharmacy, kidney function, liver function, comorbidities when we try and prescribe drugs. Most of us are not aware of conversion. But still, the question is, can adding pharmacogenomics in this milieu actually make a big difference? Do we have evidence that just adding pharmacogenomics is going to make the clinicians work much better? And that system level causal question is unanswered. And so the plan is, what do we do next? Do we what's the method by which we generate this causal level system evidence? We have other problems. There's pressure to act, and what we discovered during our last 4 years of trying to get this trial going is that there are a lot of dependencies if you want to implement pharmacogenomics, structural, educational, and other factors. And all of them are sort of developing at different paces. You need to get all of them to converge for you to implement pharmacogenomics effectively. The problem is the rate of progression. And sequencing genotyping technology has really been progressing so fast that there is pressure to just implement. The other unintended consequence is non-random rollouts can sort of poison the well, in the sense it can prevent us from generating evidence in the future, because uncontrolled implementation will sort of create a lot of biases, which will be difficult for us to disentangle if we were to post hoc try and do a trial. And then the health economic question is a big thing. If you don't have, if you implement early, there is a likelihood that you will actually incur higher costs and amplify inequalities. So those were the sort of thinking that made us realize that we have to try and generate some evidence. And therein came a problem in doing trials in pharmacogenomics is difficult. So luckily, we had Munir and the PREPARE trial, which showed that you could do trials in using panel testing. Single gene testing is straightforward. Panel pharmacogenomics becomes difficult. So we developed the Phoenix trial, and a lot of thanks to Munir and Henk Jan from Leiden, who helped us with the design. And this is the simple design. We take admitted patients in the hospital. We have the Agena panel has got 15 pharmacogenes, and that covers about 60 commonly prescribed drugs. We looked at prescribing in Glasgow, and there are about 120 commonly prescribed drugs within the NHS. 60 of them are covered by these. And we do a buccal swab testing. We randomize them to an intervention arm and a standard of care arm. Intervention arm get the pharmacogenetic result within 7 days. And a dose of medication change is advised to the physician, and then we follow up for 3 months. Standard of care, they get the PGX test at 3 months. And I just mentioned some of the pharmacogenomic value in the randomized trial. With randomization, we have the groups wherein we can balance a lot of unmeasured confounders, allele frequencies, phenoconversion, polypharmacy burden, and also contextual factors like clinical specialty, admission pathway, prescriber experience. When you randomize, you can balance those. And for blinding, again, a lot of, because we blind for outcome adjudication, we blind the analysts. We also we can't do perfect blinding, because the moment we change the drug, the patient knows. So what we are doing is, if you have a report that indicates drug change, in many cases, the patient may actually be on the right dose. They'll have an actionable variant for that drug, but they're actually on the right dose, in which case we do not unblind the patient. We keep the blinding on. Only if we have to change the drug or change the dose do we unblind. So we'll have almost 70% blinding in this trial. And finally, outcomes. We look, as I mentioned, we will look at outcomes, adverse drug reactions, and health economics. But how do we capture all the outcomes? For any drug that will lead to changes in liver or other kidney function, or CK enzyme rises. So we do a drug-specific blood test for everybody at 4 weeks. The participants complete an ADE questionnaire monthly for 3 months. They do a quality of life questionnaire monthly for 3 months. And finally, in terms of health outcomes, we get all the information from record linkage from our health records. We get all the hospitalization details for that particular admission, but also all future hospitalization over 3 months, emergency department visits, outpatient visits, and mortality. So how do we, so the next question is, can we actually do this? Because recruiting in 18 months, recruiting patients across for 60 drugs. People told us it's possibly not easy, but we've sort of cracked it. So we have hospital inpatient prescribing. There's a HEPMA database. What we want is to identify across the hospital anybody who's been prescribed one of the 60 drugs without any prior exposure to the drug. And the way we did that, through a safe haven, we built an algorithm which will pull HEPMA data every 8 hours, connect it to community prescribing. And so we know from community prescribing whether the patient had any exposure to the drug in the last 6 months or a year. And then that will prune the list down to patients that we are reasonably confident that it's a new prescription. And only then do we approach the patient. And this has been quite successful. So this is the first 400 randomizations. So from HEPMA, we got about 1,400 potentially eligible patients. The algorithm promptly excluded 783. That's 55% were excluded, which means none of the trial staff needed to approach the patient. So we avoided a manual review. 119 were ineligible with protocol. There were 524 that came to us as confirmed eligible. 80% of them we were able to convert into randomization. So that's a huge value. And that actually, you can see the numbers, 92% reduction in staff time. If we were to manually screen all of them, even if it was electronically, it still required people. It takes about an hour or so for people to look at all the health record notes, go back into patient history and establish if that was a new prescription. So that has been transformative. And I mean, everybody has got electronic prescribing now, or at least most hospitals have, and it's now could be a scalable template if we were to scale up this trial, and we are doing that in other hospitals in Glasgow now. And this is our recruitment graph. So thanks to Stephanie. Stephanie is my colleague. She's a co-investigator here, and she has been instrumental in this really successful recruitment. This is the last 7 months of recruitment. We've hit the floor running right from day one, first patient, first visit. You can see a small dip in the middle, in the July area. That's because we had, that was summer and holidays, and also 2 of our clinicians, Stephanie and Ian, were on annual leave. All this we achieved with just 2 clinicians and 2 full-time equivalent nurses. So this is the NHS 2 full-time equivalent, which means it's bits of some 10 nurses. They keep coming and going, helping with the trial. So we had a very good acceleration early on. There was a bit of a mid-stage, or a bit of a dip, but to stable. And we now have more acceleration, and that's because we brought in 2 new clinical fellows. You can see the gaps in the early stages. Those are bank holidays and weekends. We didn't recruit over weekends, but now we have 7-day recruitment because we've got new staff. We opened Glasgow Royal Infirmary last month, and Golden Jubilee Hospital is going to be open, and Mental Health Service will open end of the month. And we have a 3rd fellow joining it. And we are clinical pharmacologists, so that means whenever we see a graph, we log the graph. So we have an early exponent, but the important bit here is the middle bit. And the middle bit shows that we have not exhausted all our patients. You can see still it's a stable logarithm, so we are still accruing more and more patients. And what we are hoping with Veridose 2 and opening up the extra sites would be a second exponential phase. And So we've got 815 as of 2 days ago. If you include all the weekends from the beginning, that's an average of 3.7 randomizations per day. But if you take only the working days, then it's about 5 randomizations per day. We hope to cross 1,000 by mid-December. So how have we done with all these? We have covered the entire hospital. That's 23 specialties. The bubbles indicate the number of patients per drug in specialty. And obviously, clopidogrel is quite frequent. Omeprazole is the most frequently prescribed PPI, statins. But we have been able to get patients from ENT, from neurosurgery, gynecology. So we covered the breadth of the hospital, and we have almost 25 of the 60 drugs are represented, index drugs are represented. Male and female, so this is just the baseline, male, female, all matched randomization. That's the age distribution. So from 18 to 90 years, I think the oldest patient we have is 90. In terms of ethnicity, it's predominantly white, and this is the Glasgow area, so we don't have a lot of Afro-Caribbeans. We have some Asians, but we are capturing that information. We also have a lot of deprivation in Glasgow. I haven't got the data yet, but the Queen Elizabeth sits in the most deprived region in the UK. So we'll have a lot of inequalities within this cohort. Now, genotyping, we collect the samples in Glasgow. We FedEx it thrice a week to Houston via Memphis. And the genotyping is done in gene by gene lab in Houston. The genotype is transmitted electronically to Melbourne in Australia, where my DNA sits to do the decision support, and then the result comes back to Glasgow. It looks as though the Melbourne to Glasgow is Morse code, but yeah, we have internet, so it comes automatically and instantaneously. But the reason why I mentioned Memphis is until about a month ago, the turnaround time of less than 7 days was about 81%. But in the last 2 months, that's a Trump effect. There's somebody sitting in Memphis who sees these FedEx packages, and depends on the person, he decides, should I apply a tariff or not? And that delays transfer of samples from Memphis to Houston. And that sort of affected our turnaround time. But majority, 88% is less than 15 days, 2 weeks. The greater than 15 days is just the early teething problems, and that's all been resolved. When you look at our top drugs, the top 20 drugs by frequency, this is a heat map showing the frequency of prescribing of our index patients. Sorry, there's a Teams thing coming. Sorry. Yeah. So this is just some observational stuff. 3 genes cover 81% of the demand. 4 genes, 94%, and if you take 5 genes, it's about 100% of the demand. If you just look at our prescribing frequency of the patients, it's a real-world RCT, so it reflects the real-world prescribing. If you take drug gene pairs, 6 drug gene pairs cover 86% of the demand, and you can see that some linchpin genes are basically CYP2C19 and CYP2D6. If you attach that to specialties, you can see some sort of patterns, and this is more about what we think could be for the future for education. Certain drugs, certain genes are more frequent in certain specialties. So cardiology, medicine, surgery, and stroke, CYP2C19. ENT, surgery, it's all CYP2D6. And then antibiotics. So again, this is just data from the first 600 patients. But it again gives us a lot of information about real life patterns in prescribing in the secondary care. And acute admissions, it looks like our strategy of just focusing on secondary care is actually giving us quite a wide breadth of medicines across multiple specialties, and potentially could identify future PGX value. The last bit of my talk will be on some real-world evidence. So one is the trial. The second part is, what do we do once the trial is completed? How do we take this on to the wider NHS? So we tried to do some data analysis of our Greater Glasgow and Clyde data. So I looked at data, all the prescribing data in 1 year in 2015, and looked at older individuals. So these are adults over the age of 60. There were 471,000 adults over 50 in Greater Glasgow and Clyde. And if you can extrapolate that to the whole of Scotland, so there's about 1.4 or 1.5 million adults over 60 in the whole of Scotland. Ask the question, how many of these adults over the age of 60 got a new pharmacogenomic relevant medicine prescribed in the 12 months? And that's about 65% of them. So 305,000 patients had one pharmacogenetically relevant prescribing. And if you translate that to the whole of Scotland, it's about 1 million prescribing in 1 year. Then we looked at deprivation. So I looked at the PREPARE group of drugs. So these are the drugs that's got the highest currently evidence-based from a trial, from the PREPARE trial. So we looked at all the PREPARE drug prescribing. So that's across 12 genes. And I looked at SIMD. So in Scotland, we have the Scottish Index of Multiple Deprivation. SIMD 1 is the most deprived, and SIMD 10 is the most affluent. We looked at the affluent versus SIMD 1 most deprived risk ratios. And what we find is the affluent groups have higher reach, meaning they get prescribed more drugs, but they don't accumulate more drugs. It's the deprived groups, the red markers, they accumulate drugs. They don't stop the drugs. They are prescribed more and more drugs, and they carry a greater burden of prescribing. When you look at the within user escalation of drugs, so this is comparing with SIMD1, comparing with the most deprived. The blue line is the most affluent. They have the least escalation from one drug, whereas the more deprived you are, you have greater escalation. So if you're started on a drug, if you're from a more deprived area, you're very likely to escalate and accumulate more drugs. And these are prepared drugs, pharmacogenetic drugs, not all the drugs. The problem with, when you look at drugs prescribing, you have a problem with zeros. There are people who will not be on any drugs, and that can affect your estimates. So we did a zero inflation analysis. And what you find in the top graph is the number of drugs, the odds, sorry, the number of drugs that a person is prescribed. So that's from SIMD1 to SIMD10. And you find that as your affluence increases, the number of drugs prescribed decreases. But then you want to ask the question about zero inflation. How many people actually have no drugs prescribed? Because they do not contribute to the other analysis. And what you find is, from SIMD 1 to 10, you have the more affluent groups have a lower odds of being on zero drugs, meaning that within the SIMD 1, the most deprived, there is a considerable proportion of people who are on no drugs or no morbidities, and that could reflect lack of engagement with the healthcare system and other situations. But there are people on no drugs. So if we were to implement based on just socioeconomic status, assuming that, and we know that lower socioeconomic status have higher comorbidities, higher polypharmacy. So it may make sense that perhaps you should implement in one group, that is lower SIMD, but actually that won't make sense given the zero inflation in that group. Then in collaboration with Neil Hawkins, we did some health economics. So the only empirical data we have here is the prescribing data. We looked at deprivation, we looked at multimorbidity, so there's multiple long-term conditions, and we looked at polypharmacy. We just assumed a test cost of £100 we didn't look at all the other structural requirements because we're just looking at genotyping cost and on these prescribing. Quali, we looked at a conservative quali of 0.01 and a base case of 0.02. And these are all the combinations of all the scenarios that we modeled. We looked at clinical actioning as a very optimistic 100%, meaning if you get a report, the clinician will action. Then we look at 100%, 75%, and 50%. When you look at a quality of 0.01, everything is red, nothing is cost effective. When you do a quality of 0.02, I think 0.02 is equivalent to about 6 days of good quality life, which sort of is good for a pharmacogenetic variant. You have some green, you have evidence of benefit. And the interesting thing is the evidence of benefit is for the people with multimorbidity. That's MLTC, multiple long-term conditions, more than 5. And next is polypharmacy. Again, more than 5 drugs. All the others are not cost effective. In all the SIMD, the deprivation, all of them are all in the red. So we did that. We followed that with some sensitivity analysis. And this is to look at which variable has a more influence on the cost. And the one which has got the biggest influence on our cost estimates is quality per action. The action rate actually has absolutely no influence or very little influence. Total cost has an influence. If the cost per test goes above 300 or 500, it becomes cost effective, cost ineffective. Whereas anything between 100 to 300, it's sort of stable. You still maintain the benefit. Quality per action is interesting because what you want is, what that means is if your quality estimates are wrong, then you will have, you'll make the wrong inference. And the only way you can get that benefit is through a randomized clinical trial. You cannot get, because you need 2 matched groups to estimate the quality gain because of pharmacogenetics. So in conclusion, it's all, I'm just repeating what I said. There is a observational evidence is strong but fragmented. So there is a case for getting evidence through a randomized controlled trial. What we've shown with Phoenix is it's possible to do an RCT for panel pharmacogenomics in the US, in the UK, and we have shown that we can get the patient recruitment done at scale. We thinking to the future, we think that the next step would be if we complete Phoenix, there is still a case for doing a study in primary care. And that would be some form of cluster randomized trial or step-wedge design that would help us maintain the randomization, but also get additional implementation evidence. And so hopefully by next September, we will try and maximize our recruitment to as much as we can. And then hopefully we'll be able to provide some results. Thank you.
Sandosh, thank you so much. So much thought has gone into your design, and being able to reflect that back to us has been incredibly helpful and great to see that the recruitment's working so well.